ventilator become tired or your inotropes are not have any effect on the patient's hemodynamics, then this kind of supportive system comes into play. Now, if you see, ECMO is not a tonic, not a tablet, or not an injection. So it's not a therapeutic modality. It's a bridge. It's a support. It's a crutch when your leg is broken. So it's a bridge. Now, bridge to where? Bridge to recovery, bridge to transplant, and bridge to decision. Most of us put ECMO for bridge to recovery. Now, if somebody is suffering from a severe pneumonia with ARDS, the ventilator is causing harm, we're not being able to put up the saturation more than 80%, even on proning, even on 100% oxygen, then we think of ECMO. And putting the patient on ECMO, we let the lung go into some kind of rest. And as the pneumonia settles down, we try to put back on ventilator and take out the ECMO. This is known as bridge to recovery. Second one is the bridge to transplant. Few patients waiting for the heart and lung transplant, in between, before getting the organ, if they become ill, we put them on ECMO till your next organ is available. Third one is bridge to decision. Sometimes it happens that a patient came to an emergency having severe hemodynamic compromise. You don't know what has happened to him. So just stabilize on ECMO. Then you take this patient to cath lab to see whether any acute arterial infarction is there, or it's a pulmonary embolism or some kind of poisoning. So these three are the main bridge to ECMO. Now, if we see that in management of ARDS with severe pneumonia, ECMO has become a modality of choice when everything is failing. You are failing with the neuromuscular blockade, you are failing with proning, you are failing with the low tidal volume strategies. Then the ECMO actually chip into your place where patient can be put on lung rest. Now, if you see what we do in our ECMO, it looks like a very big name, but we do nothing. We call ourselves plumbers because we put two pipes. We put two pipes, one to take out the blue blood from the body and one to give back the red blood into the body. So only two pipes is sufficient to put the patient on ECMO. If you see, this is the thing, this is known as the drainage pipe coming out of the IVC and letting the blood out of this. Now this is a pump which actually drives this blood out of the body and push forward. And this is the oxygenator or the artificial lung where the oxygen is getting added outside the body and carbon dioxide is taken out. And then the red blood is again pushed back to another pipe into the body. So this is the tail of two pipes if you want to connect the patient on ECMO, nothing else. Now, it works like this. The blood coming out of this through the pump, through the oxygenator and goes back to the body. So you have to just ensure two pipes are put, one is the drainage, one is the return. Now if you see how long the idea has been in our mind, is not more than 100 years. So somebody in 1930 thought helplessly in the ward or the ICU, somebody is dying, his blood is getting darker, the oxygen lung is not working. How you can add oxygen into the blood without lung? And with his idea, with his thinking, they could do something in 1955 that is used as cardiopulmonary bypass machine in the operation theatre, and ECMO came out of that in 1971 for the first time with this patient. This patient had a motorcycle accident and he had a thoracic aortic rupture. The surgeons have operated on him and a lot of blood transfusion happened into the patient. And this guy actually had transfusion-related acute lung injury. Now his oxygen started falling and they made some arrangement. They call it Branson oxygenator at that point of time. Hardly if you see, find a patient here, it is a jumbled up things around the patient, and they oxygenated the guy for 3.5 days and the guy revived. So this is in 1971 at Santa Barbara. Now, as in 1975, this gives us the best hope, and we are actually practicing on because of this. She is Esperanza. She was just 1 day old when her mother actually crossed the Mexico and USA border because of some conflict, and she was pregnant, and she delivered the 1 day old child prematurely at the Michigan hospital. And one night where there is a load shedding was going on, Dr. Robert Bartlett, who was a pediatric cardiac surgeon, was there, and he actually put this baby on ECMO, 1 day old baby with meconium aspiration syndrome. The syndrome is not very much common nowadays, but that time it was very common, premature baby, and this baby revived after 6 days, and she became this big and this big. She's still alive, is 50 years old with 3 children. So, and the nurses kept her name as Esperanza, which is a Spanish term. The meaning of it is hope. So this is the first recorded event where this ECMO has been established in acute respiratory failure, and since then people have started using it. Now with that thing, in India, when we started doing practice of ECMO in different hospitals and in the conferences, this was a very usual term. Why are you use ECMO? Because it's an expensive, controversial management of oxygen deficient. And people used to laugh at us that nothing is going. Patients are dying, patients are being out of their pocket, they are in the roads, and nothing is happening. So since this is in 2010, and somebody even told this, India needs toilet, not ECMO. So ECMO is not for India. We should not practice in such a country where we have a lot of costs. This is in 2010, and exactly 10 years after that, we have actually ran for an ECMO. People have bought ECMO from their pockets to make people alive, their near and dear ones. So actually this creates necessity, the opportunity also. Now ECMO in India, if you see, we have a lot of, it has become a 2,000 to 3,000 cases per day, per year, and almost 120 systems, 120 centers, and a lot of ECMO runs are happening with very good results. Now, if you see, what are the targets? We are putting a lot of ECMO awareness programs, more machines, more on the transplants, and dedicated ECMO ICU, and we are making our own circuit so that the cost comes down by Atmanirbhar Bharat. Now, if you see, we don't leave our patients even they come out of ECMO. They are in the hospital for 2.5 months. Probably some of them lost their job, some of them lost their bank balance, and they are emotionally depressed, they cannot move, but they are disease free, and slowly they are coming into their professional life. So till then, we support them as a post-ECMO follow-up clinic. And this is the way we support them with a lot of clinical things like thromboprophylaxis, pulmonary rehabilitation for the residual lung function, psychological boosting, so that they come back professionally to their original situation where they are before the disease. Now, this is another thing which is coming into the medical science for the use, that is artificial placenta. In USA, it has been seen that a lot of babies are dying in the mother's womb between 20 to 24 weeks. And there is no means of these babies to nurture because their lungs is not mature enough to be in the environment. So what we have done, this is a phase 2 trial is going on. This is a lamb study where we put these babies on ECMO and nurture them up to 28 weeks. So this is known as artificial placenta. And this is going to come in a bigger way in 2027-28, and this is becoming a new modality of use of ECMO in those kind of patients where valuable babies who are not getting out of the womb because of the immature lung. We have a lot of transport systems. We are taking patients from different areas, remote areas also. Now, coming with some cases where this thing happened last year in our hospital. A 57-year-old diabetic hypertensive lady had an orthopnea and fever for just 1 or 3 days. just came to OPD to show a physician, and she suffered a cardiac arrest in the Apollo outdoor at around 12 o'clock in the morning. So CPR initiated by the bystander, just taken to the emergency, called for assistance, intubated, ventilated. It was continuous ventricular tachycardia going on, so somehow some ROSC achieved. Shifted to the ICU. Again, she had recurrent VP, ventricular fibrillation was going on, and recurrent cardiac arrest, ROSC. So it was going on, so we have been called to rescue her. It was a witness cardiac arrest in the OPD. And what we have done, if you see the, I don't know whether this is going to run. So look at the heart, hardly movement, any movement. So it's severe myocardial dysfunction is going on, and some kind of heart attack has happened. We don't know what has happened. Probably a history of fever for 2-3 days, might be a myocarditis kind of situation. That's why some arrhythmia had happened. And so what is rescue is possible. She's recurrently having cardiac arrest. So we taken consent from the husband, was alone with her. And this is known as the extracorporeal CPR, when conventional CPR is not allowing the life to come back within next 20 to 30 minutes of continuous CPR. We put the patients on ECMO in case of witnessed cardiac arrest. So we exactly did the same. What we have done? We have done nothing. We have put 2 pipes in the groin. One pipe is coming out and draining the blood from the IVC, and one pipe is giving back the red blood in the femoral artery. So we have just bypassed the system by putting 2 pipes, and the blood is running through the ECMO pump and the oxygenator. So this is the thing we have done, and this is the lungs. You can see severe pulmonary edema, the bad ABG with the higher lactates, and this, if the video runs, and this is the actual thing is happening. Somebody is doing CPR and we are cannulating the patient. So this is extracorporeal CPR, ECPR we told you. Patient having cardiac arrest, and this guy is continuously doing CPR. Just see, CPR is going on. I'm cannulating in her groin, and he is the perfusionist. He is making this ECMO machine ready at that point of time. So this is known as the ECPR. This is in the ICU. It's happening, and CPR is going on, and we are cannulating in the groin, the femoral artery and the femoral vein. So it takes around 20 to 30 minutes. It is easier to cannulate the vein because it is distended, and artery is not often palpable. So you just take the ultrasound and puncture it, and then push the guide wire and see. So this is the thing we do, known as the ECMO CPR. This is a little bit controlled environment in the ICU. If it happens, this is known as in-hospital cardiac arrest. This can be done in the out-of-hospital cardiac arrest. In some countries, people have taken it out. So the arrest is happening in the road, not revived after CPR. ECMO has been put on at the roadside and taken to the hospital. So this is happening, and you can't stop CPR until unless you go to the pump completely. So he is making the pump ready, and the cannulation is over. CPR is continuing. Now, if you see this, a little bit of closer view. CPR has to be continued. Now, this lady, again, after 2 days, this X-ray has been started getting clearing off. We could get some amount of lower lactates. Acidosis started disappearing, and the saturation, which was 72 with this kind of blood pressures, started improving with 94. Heart started improving. The ST changes are started settling down. The blood pressure is going up. And if you can see the reports, the SGOT was 5,000, SGPT was 3,000 because of shock lever. It has started settling over a period of time. It takes at least 72 hours on ECMO to settle down, and came down to 488 from 5,000. And this is the X-ray, and the echo started improving. And we are coming down on the ECMO flows, and this is the monitor. If you see, the tachycardia settled, ST changes are not there, blood pressure is good, the saturation is good, the ABG is good, and we could take out the, decannulate the patient. And so, what we have done, and this is the lady got survived because of this. So, this is a classical case of ECMO CPR or extracorporeal CPR. Not all patients is put on ECMO by doing this. Now, and we celebrated this. Now, a lot of similar conditions we have treated. Massive pulmonary embolism with recurrent cardiac arrest where thrombolysis get failed. Just two pipes, one in the femoral vein and one in the femoral artery. Again, this is stuck mitral valve in cardiogenic shock. This is in the right femoral vein and the left femoral artery, the return and drainage. And this is another patient where he had an MI in a different hospital. They tried to put on angioplasty, but they could not do because RC origin could not be engaged. Meanwhile, he became hypotensive with cardiogenic shock, came to us and had a cardiac arrest in the emergency. And again, if you see the echo finding, this is the echo which shows the right RV is purely dilated. This is the RV shock or RV infarct. And if you measure the TAPC of RV, which is very low, lesser than 6, so it's an RV infarct. What we have done, again we have put two pipes. This blue one is taking out the blood from the femoral vein, and this is the femoral artery. And put on ECMO. This is the same day on third day, and this is the same guy after taking out the ECMO after the heart recovered after 7 days. Now, if you see, this is the same guy after he got us physiotherapy after a year. As I told you, they need a lot of rehabilitation also. Now, this is another sepsis with ARDS, 65 years, 30 years of fever, severe ARDS, PF ratio 65, ejection fraction is 30%. The heart and lung both went down, and this is the monitor with 100% oxygen, 71 is the saturation, and blood pressure is hardly an ejection, 69/60. So both heart and lung support is needed. So we put the patient on a combined kind of ECMO, VAV, which is known as, and the heart improved on day 6, where we take out the arterial support. The lung improved on day 14, and the patient could be discharged on day 25. So this kind of acute pulmonary failures can be managed with an ECMO. Now this is the picture from the COVID. This is 160 kg and he is 170 kg. They cannot be prone. They have having severe ARDS, the lungs are tearing apart, and they cannot be prone after intubations. So we put early ECMO in this kind of patient. He is a doctor practicing in Kolkata, and he required the least duration of ECMO in COVID because we put the patient on early ECMO because we could not prone him. He took only 11 days to come out of ECMO. So in obesity, we have also published a lot of papers on obesity, ECMO in obesity. Early ECMO gives very good result if you intervene early. Now this is another for 81 days on ECMO post-pregnancy ARDS. So we have a lot of cases to show, but because of time we have published a lot of papers on ECMO. You can see this is another patient. Last year he was on transit from Thailand. He fell ill in the airport, shifted us with pulseless, saturation was not picking up, and he diagnosed with a melioidosis, which is not very much common here. It's a Southeast Asian disease, and he actually survived with us and went back to US. So acute cardiopulmonary, and if you see that some patients where we are, so I'm not going to show these videos anymore. So what we do, we put the patients on the chair when they're doing better. She was with us for 48 days on ECMO. She's on the chair, is improving lung, and slowly we have taken out her of ECMO. We cannot go away from the babies. We are doing it regularly nowadays, and this is another 1.5 years old H1N1 ARDS. In babies, we cannulate the carotid and the jugular instead of femorals because femorals are less developed. So, and he came out of ECMO on day 14. This is a patient of more than 100 days on ECMO, and he is doing fine. He was with us. So thank you. This is the last case. One of our colleagues was on ECMO for just 6 months back, and he was with us for 78 days. And you can see the bad lung. We proned him. We put him on ECMO for 78 days, and he got discharged, and he's a practicing anesthesiologist in the Kolkata. So this is a picture of this. So ECMO has helped a lot of patients where the conventional treatment gets failed. So thank you. And just keep my number as an ECMO physician and oxygen delivery boy when the lungs is not working. Just remember my name on that. Thank you.
ECMO patients are staying for a long period. So what are the risk factors for this?
Ma'am, long stays are mostly complicated by infections. The neuromuscular problem that I've shown you, that we do a lot of early mobilization, early awakening, lot of exercises are going on. And third one is the residual diseases. When even they come out, they have some fibrosis, some kind of bronchiectasis changes in the lung, which needs to be taken care in the follow-up clinic. So these are the three things you have to take care of.
Thank you very much.
ECMO, we do maintain saturation of more than 90. That's fine. Thank you.
Hello. Thank you very much.